This conference will now be recorded.
Good morning, all. Today's topic of discussion is cystic fibrosis. Coming to the introduction, it is an inherited multi-system disorder which affects mostly children and adults, and it is autosomal recessive pattern of inheritance. It is responsible for most cases of exocrine pancreatic insufficiency in early life, and it causes severe chronic lung disease in children. Cystic fibrosis is also responsible for salt depletion, nasal polyposis, pansinusitis, rectal prolapse, pancreatitis, cholelithiasis, and insulin-dependent hyperglycemia. Genetic, it is due to the mutation of CFTR gene. Cystic fibrosis, transmembrane conductance receptor gene. Pathophysiology, it is mainly due to dysfunction of cystic fibrosis transmembrane conductance regulator protein, that is CFTR. It is mainly expressed in epithelial cells of airways, like airways, gastrointestinal tract, like pancreas and including pancreas and biliary system, sweat glands, and genitourinary system. This CFTR protein functions as a chloride channel and has other regulatory functions. The alteration in this chloride transport is associated with production of thick mucus in glandular tissues, leading to retention of this mucus and predisposing to infections. In cystic fibrosis, the structures mainly involved are bronchioles and pancreatic ducts, leading to progressive destruction of these organs. Etiologies, as already told, it is mainly due to CFTR dysfunction. It is a disorder of chloride ion transport in epithelial cells. It codes for a protein known as CFTR. It is an ATP binding cassette transporter regulating chloride ion transport. Resides in surface of epithelial cells like lungs, digestive system, including pancreas, intestines, and sweat glands. Defect leads to production of thick mucus. This is the structure showing CFTR, which normally it allows for chloride conductance into the cell. Abnormality leads to defect in chloride conductance, leading to thick secretions. Pathophysiology. In the secretion, due to abnormality of CFTR, the secretions are retained and can obstruct the airways, starting from the structures with smallest caliber, like bronchioles. In pancreas and biliary ducts, obstruction leads to desiccation of these proteinaceous secretions and obstruction. The function of sweat gland duct cells is to absorb rather than secrete chloride. Due to abnormality, the salt is not retrieved from the isotonic primary sweat as it is transported to the skin surface. So chloride and sodium levels are consecutively elevated. The chronic infection is limited to airways. As a consequence of infection, it can lead to persistent colonization and inflammatory response in air walls. Patients with cystic fibrosis are more prone for infections with Staphylococcus aureus, Pseudomonas, Burkholderia sepia, which these three organisms are most common source of infections in patients with cystic fibrosis. Coming to the general manifestations, systemic manifestations due to cystic fibrosis. There will be growth failure due to malabsorption, and due to malabsorption, there will be deficiency of fat soluble vitamins like vitamin A, D, E, and K. In nose, it can lead to nasal polyps and sinusitis. In liver, it can lead to hepatic steatosis, that is fatty liver, or it can lead to portal hypertension. In gallbladder, it can cause cholelithiasis, neonatal obstructive jaundice, or biliary cirrhosis. In bones, it can cause clubbing, osteoporosis. There is malabsorption of fat, it can lead to osteoporosis. Due to malabsorption of fat-soluble vitamins like A, D, E, and K. In intestines, it can lead to meconium ileus, meconium peritonitis, rectal prolapse. Due to obstruction of this mucus plug, it can lead to meconium ileus, peritonitis, rectal prolapse, intussusception, and volvulus. In lungs, it can lead to bronchiectasis due to the obstruction of the mucus plugs. Due to obstruction of bronchioles by mucus plug, it can lead to bronchiectasis or bronchitis, bronchiolitis, pneumonia, atelectasis, etc. In heart, it can lead to right ventricular hypertrophy and pulmonary artery dilatation. In spleen, it can lead to hypersplenism. Stomach can lead to GERD. In pancreas, it can cause pancreatitis, insulin deficiency, diabetes, symptomatic hyperglycemia. In reproductive system, it can lead to infertility, amenorrhea, and delayed puberty. Clinical presentation. Patients with cystic fibrosis mostly present with recurrent respiratory tract infections, uh, or they can be asymptomatic. If patients with recurrent respiratory tract infections can present with chronic cough, wheeze, hemoptysis, or respiratory failure, or lung respiratory failure leading to right heart failure known as cor pulmonale, or they can present with clubbing, pansinusitis, or nasal polyps. In intestinal tract, they can present with meconium ileus or peritonitis. As it showed in the previous diagram, hepatobiliary, it can lead to cirrhosis, portal hypertension, pancreas, steatorrhea. They can present with frequent, bulky, greasy, and large foul-smelling stools that float in water. This is the definition of steatorrhea. They can present with malabsorption of vitamin A, D, E, and K. They can present with delayed sexual development, azoospermia, due to obstruction of due to failure of vas deferens to develop. They can also present with dry skin, salty taste to the skin, and failure to thrive. Coming to the infections, coming to the cyanopulmonary infection, they can present with allergic bronchopulmonary aspergillosis or sinusitis or polyposis. How can we diagnose it? Diagnosis is by gold standard test is sweat test. In sweat test, we will measure the chloride concentration. Normally, it will be less than 40 millimoles per liter. But in case of any abnormality, if to detect as cystic fibrosis, the chloride concentration should be 40 to 60 millimole per liter. If it is present, it will be in indeterminate or borderline. To label a patient as cystic fibrosis, the chloride concentration should be more than 60 millimole per liter. Uh, the main gold standard test to diagnose cystic fibrosis is sweat test. Next, as it is an autosomal recessive, we can screen the newborn screening and genetic test. Other ancillary tests like WBC count, glucose, the LFTs, pancreatic function test, and culture for cystic fibrosis pathogens like Pseudomonas, Burkholderia sepia, etc. And chest or abdominal X-ray. Coming to the radiological evaluation, it can be prenatal diagnosis or postnatal diagnosis or to rule out the pulmonary manifestations and extrapulmonary manifestations. Coming to the pulmonary manifestations, cystic fibrosis presents with abnormal mucus or chronic infection due to pulmonary exacerbation. Due to pulmonary exacerbation, it can lead to inflammatory response, which in turn lead to increased airflow obstruction. So, due to airflow obstruction, it can lead to atelectasis. Due to the collapse, there will be abnormal ventilation perfusion mismatch. Due to obstruction, it can also present as bronchiectasis or leading to pneumothorax or hemoptysis. As there is a abnormal ventilation perfusion mismatch, It can lead to acute and chronic hypoxia or acute or chronic hypercapnia. As there is a ventilation perfusion mismatch, means the trapped CO2 is not able to escape, and there is also inappropriate oxygenation. Due to acute and chronic hypoxia, it can lead to cor pulmonale. Due to retention of CO2, it can lead to acute or chronic respiratory failure. This is the pathway mainly important for cystic fibrosis to cause lung failure. As patients will have abnormal mucus leading to exacerbation, inflammatory response, leading to obstruction of airways, leading to collapse, leading to abnormal ventilation perfusion mismatch, leading to acute or chronic hypoxia, cor pulmonale. In chest X-ray, we'll see for hyperinflation, any hyperinflation is there or not, or bronchiectasis, any lobar collapse, any pulmonary arterial, to rule out any pulmonary arterial enlargement, to diagnose pulmonary arterial hypertension. This is the focal area showing dilatation. HRCT, it is mainly used for monitoring of CF patients and is used to guide therapy and assess the response to the treatment. It is usually repeated every 6 to 18 months. Mucus plug is of particular importance. As it is the main source, we should identify the mucus plugging as it is the main cause for exacerbations. In CT, we can see the glowing finger appearance. In coming to the nose and sinus, it will lead to postnasal drip, facial pain, nasal obstruction, and nasal discharge. On examination, there will be thickened nasal terminates or thickened mucosa of sinus. Coming to extrapulmonary manifestations, as previously done, pancreatic manifestations like steatoria, diabetes, hepatobiliary like cirrhosis, pulmonary, portal hypertension, gastrointestinal like meconium ileus, meconium peritonitis, GERD, malabsorption, renal manifestation like urolithia, renal stones, musculoskeletal manifestations like osteoporosis, as there is malabsorption of vitamin A, D, E, K. Coming to the differential diagnosis, as patients with cystic fibrosis may also present with present like a patient with recurrent aspiration or asthma or bronchopulmonary dysplasia or immotile cilia syndrome. These are the four differential diagnoses. We should distinguish these syndromes from cystic fibrosis. If patient with recurrent aspiration may have a predisposing neuromuscular abnormalities, like either patient is an alcoholic or a patient is suffering from any cerebrovascular cerebrovascular accident. In bronchiectasis, there will be lower lobe and posterior segments, as these are the dependent portions of the lung. These are most commonly affected. In asthma, there will be ABPA and bronchiectasis. As asthma is seasonal, we can rule out cystic fibrosis as it is perennial. It will be present throughout the year. We can distinguish asthma from cystic fibrosis. Coming to the bronchopulmonary dysplasia, it improves as the patient ages. It improves as they also present with recurrent aspiration. On birth history, there will be premature baby. They will have a premature baby. Coming to immotile cilia syndrome, there will be dysfunction of cilia in respiratory and auditory epithelium. Here in immotile cilia syndrome, lower lobe will be predominantly inverted, and they have associated findings like situs inversus, and they may have cardiac anomalies. These are the four DDs: recurrent aspiration, asthma, bronchopulmonary dysplasia, immotile cilia syndrome. Coming to the mainstay of CF therapy, first the medications for lung health maintenance. It includes inhaled antibiotics, inhaled mucolytics, Dornase alpha, and hepatonic saline. These are the mucolytics which help in clearing the airway. and oral anti-inflammatories like azithromycin and high-dose ibuprofen, and maintain adequate nutrition. As the patients with cystic fibrosis have malabsorption, we should supplement the patients with vitamin A, D, E, K. These are the fat-soluble vitamins which are affected, and high-calorie diet and vitamin supplements. And to boost the immunity, antioxidants like selenium, ascorbate, and zinc, and appropriate doses of pancreatic enzymes. As pancreas is also affected, leading to dysfunction, we should supplement the pancreatic enzymes. Coming to the treatment, first antibiotics and mucolytics and anti-inflammatories, and adequate nutrition with supplementation of ADK and to boost the immunity and to supplement the pancreatic enzymes. Coming to the upper respiratory tract complications, uh, these are most common. They present with running nose or nasal polyps or thick mucus secretions or sinus obstruction. They are also prone for repeated infection. Chronic inflammation lead to chronic sinusitis or exacerbation of lower respiratory tract symptoms. Coming to the lower respiratory tract complications, this is the main patients mainly have chronic lung disease, and which is the leading cause of death in 90% of patients. It is characterized by thickened mucus secretion and impaired clearance and obstruction of distal airways, leading to bacterial colonization and infection. Chronic inflammation can also lead to air trapping, atelectasis, bronchiectasis, leading to scar tissue formation, and again chronic. This is a vicious cycle with infection, obstruction, and infection. Finally leading to the respiratory failure, which is the most common cause of death in patients with cystic fibrosis. As it is an obstructive airway disease, patients will present with decreased forced vital capacity, decreased forced expiratory volume in first second, mucus infection, inflammation, and the cycle of infection. This is the vicious cycle. Mucus plugs leading to microorganisms are trapped in the lungs, lead to infection. The body defenses against the infection, body defenses against infection are activated, leading to more mucus production, leading to deposition of mucus plugs. This is a sequelae. As patients have abnormality in clearance of mucus plug, they are more prone for infection. As to combat infection, our body defense will activate, leading to more mucus production. It will be a sequelae. Finally, there will be deposition of mucus plug and obstruction, leading to respiratory failure. These are the commonest respiratory pathogens: Haemophilus influenza, Staphylococcus aureus, Pseudomonas aeruginosa, Burkholderia sepia, and coming to the fungi, Aspergillus. Treatment for the complications, mainly antibiotics. We should select the antibiotics based on the culture reports. For oral antibiotics are mainly for mild exacerbations, penicillins and cephalosporins, like dicloxacillin, amoxiclav, cefalexin, or Septra. We can also go for fluoroquinolones like levofloxacin and moxifloxacin. Coming to the macrolides, azithromycin and clarithromycin. For mild exacerbations, we can go for oral treatment with penicillin, cephalosporins, fluoroquinolones, or macrolides. For acute exacerbations or chronic suppression, we'll go for inhaled antibiotics like tobramycin, colistin, azitrionum. For moderate to severe exacerbations, we'll go for IV antibiotics for aminoglycosides like tobramycin and gentamicin, plus beta-lactam and its inhibitors like piperacillin, ticaracillin, or third, fourth generation cephalosporins, or carbapenem, meropenem, imipenem. As there is obstruction of mucus, To clear the airway from these mucus secretions, we'll use some techniques. These are respiratory clearance devices. We can go for natural methods or by using mechanical devices. Natural airway clearance methods, coughing, or we'll go for handheld percussion or chest physiotherapy. Chest physiotherapy, it again includes postural drainage. As we have discussed in previous class, for bronchiectasis, different positions for postural draining. Same technique, same postural drainage techniques are used for patients with cystic fibrosis. And another technique is percussion. Another way to clear the airway is activate cycle of breathing technique, or we'll go for self drainage. By using mechanical devices, we can clear the secretions by which includes flutter valve devices with positive expiratory pressure, or high frequency chest wall compression devices, or intrapulmonary percussion ventilation devices. For UGs, we will these airway clear natural airway clearance methods are, you should remember this at least: coughing, handheld percussion, chest physical therapy, or self drainage techniques. Coming to the other inhaled pharmacotherapy, uh, mucolytics. Coming to the mucolytics, it includes Dornase alpha, also known as pulmozyme. Its main mechanism of action is it will cleave the DNA strands in airway secretions to decrease mucus viscosity and improve lung function. It given in a dose of 2.5 mg 1 to 4 times daily in a nebulized form. One mucolytic is Dornase alpha, another hypertonic saline. Its mechanism of action is it will improve the movement of salt in and out of the cells, allowing the mucus to be more hydrated and clear more easily. Dosage, will give it in 4 ml 1 to 4 times daily in nebulized form. Coming to the bronchodilators, albuterol. It is a short-acting beta-adrenergic agonist given in nebulized form, 2.5 mg 2 to 4 times daily. 2 puffs in nebulized form will go for 2.5 mg 2 to 4 times daily. For inhalation, 2 puffs 2 to 4 times daily. These are the mucolytics, Dornase alpha and hypertonic saline. Next, inhaled forms are bronchodilators. One is albuterol. And coming to the treatment of pulmonary inflammation, anti-inflammatory agents like azithromycin, ibuprofen, steroids will use these drugs. Coming to the action of anti-inflammatory agents, their main mechanism of action is they will decrease the inflammation in lungs and will decrease the chronic damage to the lung tissue. Uh, Main anti-inflammatory agents used are ibuprofen, steroids, and azithromycin. Ibuprofen, it will give in a dosage of 15 to 30 milligrams per kg, 12th hourly. Steroids will go for short-term therapy. Inhaled steroids will use in patients with asthma, allergy, or upper respiratory tract symptoms. Coming to the next anti-inflammatory agent, azithromycin, used in a dosage of 250 to 500 milligrams daily. Coming to the nutritional support, as most patients have increased caloric needs due to increased expenditure, as there is malabsorption, we'll go for high calorie diet, including vitamin supplements, fat soluble like vitamins like A, D, E, K. The combination we'll use are Vitamax, Aquadex, Source CF, and calcium to improve the bone health, and iron to combat the anemia and to boost the immunity. And cystic fibrosis patients are more prone for antioxidants, we'll use selenium, ascorbate, and zinc to boost the immunity. As patients may have pancreatic infection, as pancreas is also affected, to replace it, we'll go for pancreatic enzymes, and or surgical replacement with G-tube or J-tube if patient have if oral supplementation fail or patient is in severe disease. Coming to the pancreatic enzyme, Uh, as patients with cystic fibrosis mostly 80 to 90% of patients have pancreatic enzyme insufficiency. Uh, the enzymes which are deficient include proteases like trypsin and chymotrypsin and carboxypeptide. The mechanism of action of this trypsin is it will cleave proteins to peptides. This trypsin and chymotrypsin will cleave the proteins to peptides, and this carboxypeptidase will cleave peptides to amino acids. These are deficient in patients with cystic fibrosis, which digest proteins. Next, they are also deficient in amylase. It will digest carbohydrates. Like it will convert starch, complex carbohydrate into simple, like maltose. It will convert starch to maltose. And they will have deficiency of lipase, which will digest fats. It will convert dietary fat into monoglycerides and fatty acids. So patients with cystic fibrosis who have deficiency of these proteases, amylases, lipases, and bile salts, as liver is also affected. So to replace these enzymes, as these enzymes are essential for normal digestive function and for digestion of proteins, lipids, and fat and carbohydrates, we should replace these patients with these enzymes. So, normal dosage of lipase is 500 to 2500 units per kg per meal, or we'll go for 10,000 units per kg per day. They should be taken with meals or snacks. The commonly used pancreatic enzyme replacers are pancrease, creon, and zenpep. These are the most commonly available products. Coming to the pancreatic complications, due to pancreatic insufficiency, they will have deficiency of these protease, amylase, and lipase. So there will be malabsorption. So we will go for replacement. They are due to as pancreas is also affected, they are more prone for diabetes. Coming to the hepatobiliary complications like gallstones, we'll go for cholecystectomy, or we'll treat with ursodiol in 8 to 10 mg per kg per day in 2 to 3 divided doses. In patients with the focal biliary cirrhosis, we'll go for management of end-stage liver disease with transplantation or ursodiol. Coming to the abnormalities in sweat glands, as they have increased sodium and chloride, as it is not reabsorbed into the cell, we'll treat them with fluids and advise them not to go in areas where there is high humidity. Coming to the musculoskeletal disorders, we'll treat with calcium and vitamin D supplementation and bisphosphonates. And for joint pain, we'll go for analgesics. As they are most prone for anemia, they will treat with iron supplements. These are the future therapies. As it is inherited as an autosomal recessive disorder, we can screen it in the newborn baby or by genetic testing, and we'll go for recommended therapy. Coming to these future therapies, these are gene therapy by using plasmid and CFTR modulator. As the main culprit is CFTR, we'll go for CFTR modulators like Etelrin, VX809, and Calidio. And as there are atelectasis, we'll go for surfactants like bronchitol. As these are most prone for infections, we'll go for inhaled fluoroquinolones. These are in under trials. There are no inhaled fluoroquinolones at present. And phosphomycin and tobramycin. These are the aminoglycosides. And anti-inflammatories, inhaled form. These are in inhaled form, like glutathione and sildenafil and DHA, dihydroketoacetate. And transplantation. Inhaled cyclosporine. And coming to the nutrition, liprotamase. Roll number 100. Turn on your mic. Roll number 100. 1 or 2. Can anyone tell most common infections in patients with cystic fibrosis? Most common organisms?